Hospital and the clinical pharmacist in cardiac ICU at Ramakrishna Hospital. She is experienced in treating patients and supporting pharmacists and physicians with info about appropriate dosage and protocols, well versed in pediatric and neonatal dosing and antimicrobial infusions, medications, contraindications, interactions, and side effects. We are grateful for having you here, ma'am, and the stage is yours.
Yeah, thank you for your brief introduction to me. Uh, I hope I'm audible to you all.
Yeah, ma'am, you're audible.
Yeah, okay, thank you. Can I have my slides, please? Yeah, thank you. So, warm good evening to everyone here. So, myself, Dr. Aarti Chandran. I'm a pediatric and neonatal clinical pharmacist practicing at Sri Ramakrishna Hospital. So, today I'll be sharing with you about the pediatric pharmacy specializations and how you can find your niche and how you can grow in this field. So, I'll be sharing in my experiences in pediatrics. Uh, Without any delay, I would like to carry it forward. Next slide, please. So, in short, I will tell about my journey of how I came after family into a clinical pharmacist and how I entered into pediatric specialization. So, I finished my family graduation at the year December 2022. And soon after that, I got placed in Sri Ramakrishna Hospital as a pediatric clinical pharmacist. So initially, it was a very new area for me also. So I slowly started developing in pediatric patients how peculiar they are, how their dosings are different from adults. So slowly, I started developing interest over there and I moved into pediatric critical areas. So I always believe in one line that you have to always establish yourself, especially if you are a clinical pharmacist, you have to prove that you are valuable. You have to show that you are knowledgeable in all the aspects of our drugs so that only you will be recognized. So, in short, this is my journey from being a family intern to a clinical pharmacist. So, today I will be sharing about few key competencies as a pediatric clinical pharmacist should be very specific about. Okay, so I will be sharing about the pharmacokinetic and pharmacodynamic variations in pediatric patients comparing to adults. So, with this, how the pediatric dosings varies and intravenous drug dilutions, which is a very crucial area for a clinical pharmacist to be very careful of, and medication errors, which is a common and fatal thing happening in pediatrics, and antimicrobial stewardship in pediatrics, and how a clinical pharmacist can help contribute in antimicrobial stewardship, and few of the standard dose references books for pediatric dosings. Next slide, please. So why you always wonder why we babies need precise dosing? Like adults, they all have a standard dose, but babies they vary with the weight, height, everything. Why do babies need precise dosing? I think everyone have wondered about this particular question. Why do they need a exact precise dosings? The reason is because they are varying, they are growing, they are not like a standard adult who has been in a similar height, weight, and all. Every day, every minutes, they are growing. So they are growing individuals. So there are pharmacokinetic changes in pediatric patients compared to adults, like their gastric pH variations and immature hepatic and renal parameters, which will again affect the drug's metabolism. And in premature babies, there are certain capacity limited metabolism and excretion. So So all these together make them a very peculiar population. So we need to be very precise about their dosings. Next slide, please. Next slide, please. So, as we all know, pharmacokinetics is about absorption of the drug, its distribution, how it is metabolized, and how it is eliminated. So, I'll be sharing few different aspects from adults in pediatric population, how the pharmacokinetic varies. So, in case of absorption, the neonates and infants will always have an elevated gastric pH. So, this affects the absorption of most of the acidic drugs and weakly acidic drugs. And next comes is the delayed gastric emptying. Compared to adults, neonates have a decreased intestinal motility, and their feeding status, their type of feed, everything will affect the gastric emptying in the neonatal populations and in young infants. So this delayed gastric emptying also further affects the absorption of a drug. And one of the commonly used route of administration in pediatric patients is the rectal drug administration. So this is also affected by certain factors like the blood supply over the hemorrhoidal veins and arteries, and there will be a greater number of amplitudes and pulsating contractions in the lower intestines of the younger infants. So this will cause easily expulsion of the drug we administer. So this is another factor which affects the rectal absorption of drugs in kids. And another commonly used route is percutaneous or intramuscular route. So this is again affected by the increased capillary densities and the thickness of the stratum corneum. And usually the neonates have a larger surface area to skin volume ratio, which will increase the absorption of many drugs. And the skin hydration, as we all know, pediatric kids, right from the preterm term neonates, everyone will have a higher body content rather than body water content rather than the fat content. So this will also increase the absorption of many of drugs like steroids and all. So it is easily causing toxicity in this population. And moving to the distribution, the changes in the volume of the drug affects the half-life of the drug. So as we all know, highly distributed drug will have a longer half-life, and the shorter distributed drugs will have a shorter half-life. So in neonates and pediatric population, the total plasma concentrations of the proteins is about 86% of that is. So this decreased protein binding increases the free fraction of the drugs, which will be able to penetrate to everywhere of the body, needing higher volumes of distribution. And then another factor is which will be particularly seen in neonates is that hyperbilirubinemia. It could be either passive or active neonatal hyperbilirubinemia. So in these patients, the drugs which are bound to albumin will be competing for the binding sites with the bilirubin, which can increase their hyperbilirubinemia and can also cause kernel icterus. And also the body composition, as I have said before, that the children have more body water content than adults, so this will also affect the absorption of drugs. So this is a graph which shows the total protein and albumin content in fetal, neonatal stage and adult stage. You can see there is a gradual increase during the adult stage. Next slide, please. So here I have took a few examples to show you how the protein binding affects the clinical responses of a drug. In the first graph, you can see that in fetal stage and neonatal and adult stage, how the protein binding varies for each drug. So in fetal stage, the percentage of protein binding is very less. It is increases in adult stage, and it furthermore increases in the adult stage. So again, as I have said, in the hyperbilirubinemia conditions, they will be competing for the albumin binding sites between the bilirubins and the drugs, which can also increase the drug concentrations in the serum. Next slide. Next, moving to the metabolism, we all know that the liver metabolism is a major metabolic pathway for elimination of our drugs. So, we have two types of metabolic pathways, phase 1 and phase 2 reactions. So, certain phase 1 enzymes are not fully developed during the childhood, and certain enzymes are usually developed during the first 6 months of the life, but it gradually decreases during the adult stage. So, these are certain enzymes like CYP 2P2A6, 2B6, 2C9, 2C19, and 2D6. So all these hepatic enzymes will reach their adult activity in 6 to 12 months of their age, and in particular CD 2C19 will actually reach the adult level within 6 months, and also reach their adult level within the puberty time. So all these variations also affect the metabolism of drugs which are being metabolized by these particular enzymes. And the very particular enzyme is CYP3A4. So they usually reach their adult concentrations by 6 months of the age, and their activity may exceed the adult stage between the age of 1 to 5 years, but it usually returns to the adult activity after their puberty stages. And phase two reactions like glucuronidation, uridase transportase, everything will reach its full stage by the 3 years of life. So this again affects the metabolism of majority of the drugs like anti-epileptics, anticoagulants, which are being metabolized by these enzymes, and certain drugs which requires conversion into their active form by these enzymes are affected. And another factor is increased hepatic blood flow in infant stage. So this will increase the extraction ratio of drugs which undergoes first pass metabolism. A very good example you can always remember is propranolol. So propranolol undergoes extensive first pass metabolism. And certain studies have also highlighted that the diet and maturation of the hepatic enzymes also affect the metabolism of drugs. A very good example is a caffeine metabolism. So caffeine is metabolized by CYP1A2 enzymes. So usually in formula fed infants rather than compared to breastfed infants, there is an accelerated metabolism of caffeine. So it is been said that these formulas are acting like a hepatic enzyme induces and increases the metabolism of these drugs. Next slide, please. So moving to the last one is elimination. We all know that renal and hepatic are the major elimination pathways. In concern to the renal pathways, the renal function is usually low in preterm and term infants, and it usually takes about 2 years of their life to reach the adult stages. So the glomerular filtration rate reaches the adult level by only 2 years of life. So always when you are prescribing the drugs which are renally excreted and having a narrow therapeutic index, there should be a close monitoring needed for these drugs, as they can easily cause nephrotoxicity of these drugs. So here I have provided you with a graph like you can see how the half-life increases in preterm neonates and it slowly decreases in term neonates and in adults. So increased half-life means the drug is excreted very slowly in the body from the body. This is correlated due to their renal maturation effects. Next slide, please. Next slide. So in this table, you can have a brief outlook about how the various factors affect the absorption of certain commonly used drugs. So in absorption, the oral gastric pH increase decreases the bioavailability of drugs like phenytoin and phenobarbital, and increased gastric emptying causes delayed absorption of these drugs, and the intestinal enzymes decrease and increases affects the bioavailability of certain drugs which undergoes metabolism by these drugs. And I also said before, the percutaneous absorption usually increases in the in the neonates and pediatric population. So this increases the bioavailability. A very good example is topical used steroids, and the intramuscular absorption will be varied, and there are we cannot predict like this much of will be the bioavailability will be increasing or decreasing like that. And higher body water content compared to fat content also increases the volume of distribution of hydrophilic drugs and decreases the volume of distribution of lipophilic drugs. And the protein binding is decreased, which increases the free fraction of drugs, which can easily cause toxicity of most protein bound drugs. And hepatic metabolisms decreases in the neonatal stage. So always these drugs which could cause with narrow therapeutic index should be dosed very carefully in this population. And excretion, the glomerular filtration rate and tubular reabsorption will be reduced in the kids population. So always the drugs which are renally excreted and having a narrow therapeutic index should be dosed very carefully. Next slide. So far we have seen like how the absorption, distribution, metabolism, and elimination is varying in kids populations from compared to adults. So how does the pediatric dosing differ from adults? So always keep in mind one point, that kids are not just tiny adults. Whatever suit the adult population will not suit them. Not the like half of the dose or quarter of the adult dose will not be equal for them. So they need a peculiar dosing measures. So always, always the dosing will be based on the age of the children, the weight, body weight, or either body surface area of the children. Next, please. So age based on the body weight or based on body surface area. So these like this we will have to dose these children. Next slide. So, if you have to know about the age, so this is what we classify in the pediatric age group. For first is newborn or called as neonates, and in the newborns we can classify them as preterm and full term neonates. So preterm neonates are usually born before 34 weeks of their gestational age, and full term neonates are between 38 to 42 weeks of gestation age. Infants populations include from 1 month to 12 months of age, and children includes toddlers and older children. 1 to 5 years children are called as toddlers, and older children are 6 to 12 years. And above 12, that is 13 to 18 population, we call them as adolescents. So next slide. So in neonatal population, we classify the preterm neonates based on their gestation age as extremely preterm, very preterm, moderate preterm. Under moderate preterm, there are early moderate preterm and late moderate preterm. So depending on these age parameters, also neonatal dosing varies. Next, please. So age based on dosing. So it is usually followed in neonatal population. So certain drugs are based on their gestational age and postnatal age, the dosing and dose interval, everything varies. So you can see an example table. This is the example of gentamicin dosing in neonates. So the in children who are born at 29 weeks or below, in the postnatal age 0 to 7 days, the dose should be 5 mg per kg, and the dosing interval should be 48 hours. Likewise, depending on their age, their postnatal days, the postnatal age, or how many days after the birth they are, and the dose varies, and the dosing interval also varies. So these populations need precise dosing. As I said before, certain drugs which are renally excreted or hepatically metabolized should be very carefully dosed in neonatal populations based on their age, their weight. Next slide, please. Next is weight-based dosing. This is a commonly used for many drugs. For most of the drugs, I could say around 95 to 98% of drugs will be dosed based on their body weight. A very good example is paracetamol. So paracetamol, we all know that 10 to 15 mg per kg per dose every 4 to 6 hourly can be given in children. Next is body surface area dosing. So body surface area based dosings will be commonly you can see in oncological drugs, oncotherapeutic agents, and another set of drugs like antiarrhythmic drugs. A very good example is flecainide. So it is dosed like 50 to 100 mg per meter square per day when divided every 8 to 12 hourly doses. So usually the dosing varies with the age, weight, and body surface area. So the next thing, as a pediatric clinical pharmacist, you should know how to calculate the dose, because we don't have commercially available pediatric formulations for every drug. We have only for fewer drugs, but we don't have for every drugs. So you should always remember this particular formula. The volume required, or ml, or the strength required, is you should know first. So which is equal to strength required, whatever the dose prescribed for the child, divided by the available strength, whatever you have available commercially, into volume of this stock solution, that is in how much ml. So for example, if you need 10 mg of a drug. Okay, so it is available as 100 mg in 5 ml of syrup. So required you need is 10 divided by 100 into 5 ml has 100 mg. So that is the volume of stock solution into 5. So you need to remember this particular calculation to dose the children. Next. So here I would tell you with fewer examples. So if you have an 8-year example, you imagine you are having an 8-year-old child who weighs 12 kg is being prescribed with levetiracetam 10 mg per kg every 12 hours. So the dose needed for this particular child is 120 mg. That is 10 mg into 12 is 120 mg every 12th hourly. So with that formula, you will get the answer. Next. So as I said, like 120 divided by 100 into each ml of the levetiracetam solution is having 100 mg. Okay, so that is into 1. So that is equal to 1.2 ml. So if you have to give 120 mg, you have to give 1.2 ml of the syrup. So that is how you calculate the syrup. And this suits for injections also. So you are, imagine you have a 2-year-old child weighs 8 kg and have been prescribed with ceftriaxone 50 mg per kg per dose. So every 12th hourly you need to give 200 mg, but you have commercially available is only 500 mg. So imagine you what you want is 200 and what you have in your hand is 500. And if you're diluting this whole thing in a 5 or 10 ml of solution, you can get the whole answer. Next, please. Next, please. Next, please. Am I audible? Yeah, next slide, please. Yeah, uh, a little bit forward, please. Uh, can you move to the previous slide, please? Okay, so so this is the answer how you get. So 200 is what you need and 500 is what you in hand. And imagine if you are dissolving the whole thing in 5 ml. So you need to take 2 ml after reconstitution of this whole drug. Okay, so this is how you dose the children population. Okay, next. So another thing as a pediatric clinical pharmacist you need to know is the maintenance fluid rates. Like in adults, we cannot give a larger volume of fluids. So depending on the weight of the child, so there is a particular for rule we what we call as 4:2:1 rule, especially for pediatric maintenance fluid calculations. So this thing you can refer all the time. Okay, so if the child weighs less than 10 kg, their hourly fluid intake should be 4 ml per kg per hour. So this particular thing will be very important when you have to give IV doses for the drugs. So how much ml of fluid it should take. Unlike adults, you cannot give a whole bunch of 100 or 500 ml of fluids to the kids, which will be overloading, and again you will lose your IV site swelling, everything can happen. So this is based on their weight, how much hourly fluid they need, and what is their daily fluid requirement. Next, please. Okay, so as a pediatric clinical pharmacist, you should also be strong in intravenous drug dilutions. Okay, so intravenous drugs are in usually in kids we give as IV bolus or slow IV push or intermittent or continuous IV infusions. So fluid management in pediatric patients is very important aspect, especially in critically ill children, because in critically ill children we will be having a multiple dilutions. Previous slide, please. we will be having a multiple IV drugs simultaneously going for these patients. So we should be careful with the not to over volume them or under dilute those drugs. Okay, so overloading, inappropriate diluent usage, improper dilution techniques, and improper storage and stability are common issues when intravenous drugs are being prescribed for pediatric patients. As we all know that most of the fluids dilutions or calculations or intravenous drug dosings are available only for adult populations, and which does not suit for the pediatric patients, and we have very few guidelines on IV drugs. Next, please. Next, please. So I always say that to have a standardized protocol and to reduce the errors associated with intravenous drug administration in pediatric populations, always I would recommend that prepare an institutional based guidelines. So this is an example of guidelines which we have made for our hospital. So we clinical pharmacists and pediatric consultants together, we have prepared an intravenous antimicrobial infusion protocol only for pediatric patients. So you can take the commonly used antimicrobial agents in your hospital, and you can give them the standard dosing on what is the compatible IV fluid used for the particular drug, and what is the maximum concentration we should give. And if you can give it as a bolus or an infusion, or you can give it as a continuous or intermittent infusion, all those recommendations you can write over there. And if storage is needed, we can mention all the storage parameters, like how long you can storage, under what conditions you should storage these drugs, and certain important points, like if you are using like amphotericin B, it should not be mixed with any sodium and fluorides containing solutions, and you should use inline filters. So all these points can collaborate together and put it as a one guideline which you can use for your own institution. Next, please. Next, please. Next slide. Okay, so far we have seen what all the drug dosing techniques and how you should do the dilutions, all those things. Next, commonly encountered problem in pediatric patients is the medication errors. So it is commonly seen as prescribing errors, dispensing and administration errors. So these three things are very common among pediatric populations. Prescribing error can be due to wrong drug calculation or wrong dosing, wrong route prescribed, wrong drug is being prescribed, or lack of knowledge about the dose of particular drugs, or in improper frequency is being prescribed. So all these contributes to prescribing errors and dispensing errors. Like I said, like we don't have particular tailored formulations for all the drugs for pediatric populations. So certain adult formulations only we still have to use on pediatric formulations, and this is like again putting us in trouble. Next is administration errors. Again, giving a wrong route of administration, wrong dose calculation, which can overdose or underdose the child, and a wrong frequency or wrong time of administration of drugs. So all these three are major and fatal medication errors for pediatric patients. Next, please. So here I will discuss it like case scenarios which we have encountered in our hospital, and we have rectified it. So imagine a 3-year-old child is being treated for congestive heart failure and he weighs 10 kg. So the doctor prescribed the furosemide tablet 40 mg every 12th hourly. So this itself is quite a very thing, because 3-year-old child doesn't need a 40 mg of furosemide dose. So after administering 1 or 2 doses to this child, the hourly urine output almost double, and 24-hour urine output reached more than 3000 ml per day. Okay, so the child looked extremely lethargic and dehydrated. So the reason is the wrong dose or overdose has been prescribed by the clinician. Next, please. Yeah, so the usual dose in for furosemide is 1 to 2 mg per kg every 12th hourly for pediatric population. So actually, this child only needed 10 to 20 mg, which is almost half the prescribed dose. And another case scenario is a 3-day-old neonate weighing 2.5 kg is in heart failure with recurring AF, it's atrial fibrillation. So the pediatrician orders 5 mics per kg of digoxin, so which is 0.125 mg based on the weight of this child. So this is a commercially available injection with us, which has zero point 0.5 mg per 2 ml. So we should be very careful about the dosing. So the dose for digoxin is in mites per kg, but what we have in our hand will be milligrams. Okay, so you should always be convert into what into the unit what we need to have, and then only we have to calculate. So actually they should give us zero point 0.5 ml, zero point 0.05 ml, but while transcribing the order it was misplaced and transcribed as 0.05 ml. So again, missing a decimal point in the prescription can lead to fatal errors. Next, please. Next is the administration error. So administration, I said like wrong dose calculation, wrong route of administration, wrong timing, wrong formulation being administered. All these can contribute to administration errors. I said like we don't have tailored formulations for pediatric patients. So whatever commercially made for adult population, from that only we have to dose for pediatric patients. So this is a case scenario where the wrong drug dose was calculation happened. The 34-week born with presumed early onset sepsis was prescribed with injection clavum 80 mg. By calculating the dose is amoxicillin 30 mg per kg. So we have a commercially available formulation 150 mg of amoxicillin clavulanate, which is 125 mg of amoxicillin and 25 mg of clavulanate. So after reconstitution of this preparation with 5 ml of sterile water, the concentration of amoxicillin will be 25 mg per ml. But the staff nurses calculated the total dose as 50 mg per ml. That is by adding together like amoxicillin and clavulanate dose. So always when you have a combination like beta lactamase or whatever combination preparations you have, always go for the base ingredient. Okay, if you refer anywhere you don't have the proper dosage for this beta lactam inhibitors in pediatric population, so always be careful with the dosings in such kind of population. Of course, we cannot physically separate these formulations, but we should always calculate for the beta lactam component in those particular antibiotics. Next is an administration error. Wrong administration time is being followed. Okay, so this can happen in any scenarios where there will like where there is multiple patients, short staffing time, or hurry burry time. It can happen at any point of time. So 1-year-old child is prescribed with injection amikacin 15 mg per kg per dose, which is to be administered every 24 hours. But the staff nurse administered the drug after every 12 hours. So this is again, I already said like amikacin is a nephrotoxic drug, and in children it can easily cause nephrotoxicity. So wrong administration time could affect their functionality. Next. Next is our drug dilution error. So this is also comes under administration errors. So a 4-year-old child is being prescribed with injection acyclovir 300 mg every 8 hourly dose. So ideally this acyclovir injection should be diluted in at least 30 ml of NS normal saline solution and should be infused over 1 hour. So at least 30 ml of the fluid should be used in pediatric populations, 30 to maximum of 100 mg depending on their weights. Okay, but it was administered as an undiluted and rapid push was given for by the staff nurse. So this immediately caused the IV site swelling, pain, and the child was in extreme pain. There was a mild extravasation of the site, and there was an picture of acute kidney injury in the site. So we need to dilute these formulas is very important. Certain drugs, very few drugs only we can give as IV push or bolus drug, but not all the drugs. Ideally, every drug in pediatrics need dilution. Next is the dispensing error. So this happened for a 21-year-old moderate preterm baby who was experiencing GERD and was prescribed with syrup Donstal zero point 0.3 ml every 12 hours. Okay, so the staff nurse immediately raised the orders to the pharmacy, and the pharmacy processed the order and dispensed this particular drug, which is Donstal baby drops, okay, instead of a syrup. So this contains each ml contains 10 mg of the drug, but what we actually needed was 1 mg suspension. Okay, so this is 10 times more potent than what we have prescribed. So without checking the orders, the staff nurse, if they administer this as 0.3 ml, it will go like 3 mg of the drug. So again, more dose will be administered for the child. Next, please. So this one is the one we actually want, which contains each ml will have 1 mg, but for what their pharmacy dispensed is 10 times more potent than what we actually prescribed. Next, please. So, as a pediatric clinical pharmacist, how you should be vigilant about these drugs are you should always recheck and verify every medication orders in the chart and ensure the calculations are made right. Each dose is being calculated according to their weight and the weight is right. Everything, especially in neonates population, they are growing. So at least every weekly you should be right about the dose. Is the particular dose prescribed is right, or we should increase the dose or decrease the dose? Everything you have to check. And if you have any of the changes to be made, you always refer back to the physician. And even if you have any of the clarifications, always refer back to the physicians, so that as a team you can reduce the medication errors and verify the dispensed medications from the pharmacy, and educate and train the staff nurses in dose calculation and dilution technique, because the staff nurses are the people who are involved in administration of these drugs. So next my talk will be on of antimicrobial stewardship in pediatrics. So this is not a very much explored area like antimicrobial stewardship in adult population. Next please. So why do we need antimicrobial stewardship in pediatric patients? So antimicrobial resistance in children is very much underreported or underseen in patients. So it is due to children are more likely to get more amount of antibiotics than adults for infection, for any kind of infections. And this is mainly due to certain causes, like in outpatient settings, it is major concern is parental concerns, because the parents always believe that their child needs an antibiotic for any kind of infection, then only they feel like that their child is okay. And another common mindset among the health care setting is that the children are immunocompromised, their children are more prone to infections, and especially they need an antibiotic for every illnesses. So they get more recurrent antibiotics, and this can happen in when the parents refill the prescription. So once when the child is having some kind of infection, initially the clinician would have given any antibiotics along with some other medications. So whenever the child is getting similar sort of illnesses, the parents used to refill these antibiotics along with other medications. So they are being getting recurrent antibiotics and over usage of antibiotics for viral infections. So usually the children with respiratory tract infections, gastrointestinal tract infections, which could be viral infections, are being prescribed with antibiotics, which is of no use and no indications. So always be careful with for the viral infections. There is no need of an antibiotics. Next is the microbiological profile of and antimicrobial pattern in antimicrobial resistant pattern in children are often underreported or lost in the nationwide data. So the resistant patterns among the children is not properly known. We don't have enough data to study all these things, and the lack of pharmacokinetic and pharmacodynamic studies and lack of suitable drug formulations for the pediatric patients, and the lack of suitable formulations, especially higher end antibiotics, are not there for pediatric populations, and these are not very much studied in pediatric populations also. So, and I already said like parental expectations for the need of antibiotics. So all these factors are contributing to antimicrobial resistance in children. Next, please. So here are the few key areas where you can how to start an antimicrobial stewardship in pediatric populations. So timely management is the first and foremost thing. Okay, so you should have a, prompt initiation of antimicrobial agents when there is a profound or suspected bacterial infection is there, and avoid antimicrobial agents in viral infections like upper respiratory tract infections without any evidences of bacterial infections, and always go with the guidelines rather than being randomly thinking like if there is a elevated infection markers, it could be definitely viral or it could be definitely bacterial, and blindly prescribing a higher end antibiotic. So appropriate selection of antibiotic plays a major role. So select an appropriate regimen which suits the particular infection, the particular site of infection, or the particular organisms which we are suspecting. Okay, rather than going with going blindly. So appropriate administration and de-escalation of antibiotics. So once after you start the child on an empiric antibiotic regimen, suspecting the this could be the pathogens or this could be the site of infections. So once after getting your culture reports, always optimize the therapy, that is de-escalate the dose to a narrow therapeutic regimen rather than continuing with that same broad spectrum agent, and use of expertise and resources. So always have a team of members along with you, because antimicrobial stewardship is always a teamwork. Now no one person can do it in their own. Okay, so we should have a good team effort for implementing a good antimicrobial stewardship, and continuous and transparent monitoring of antibiotic and antimicrobial resistance. So always get updated with the available informations and commonly resistant organisms in your hospital, and what kind of antibiotic agents you should be using for these patients, and if it suits your neonatal and pediatric population. So always be updated. So these are some key areas where you have to be updated. So as a pediatric clinical pharmacist, what you can contribute to the NSP? So you can assist in developing an antibiotic policy for common illnesses in pediatric population, which suits your hospital, which suits your geographic location, and what kind of commonly infecting pathogens are there in your areas, and develop an antimicrobial dosing guidelines in children and neonates. As we have seen, there will be a lot of references, and the various discrepancies will be there. So always populate a guideline for your own hospital for the antimicrobial dosings, and monitor the days of therapy to evaluate the antimicrobial prescribing. And there should be a timely escalation and de-escalation, and IV to oral switch of antibiotics should be there in pediatric populations. Next. So, so far we have seen so much about how you can be a successful pediatric clinical pharmacist. And these are the few standard references you can search for pediatric dosings, administrations, and pediatric pharmacokinetic data. Everything you can check for with these standard doses like Micromedex, Lexicomp, and drug dosages in children by Meher Bansing, Harriet Lane Handbook, the teddy bear book. This teddy bear book is particularly for injectable drugs. You will have an entire monograph of all the injectable drugs, like how they should be diluted, what is the maximum concentration, how they should be dosed, everything according to the infection or whatever indication is the drug is being used, everything will be there. And you can also refer drug doses by Frank Sean. So these are some standard references for pediatric drug doses. And another query often you encounter in neonatal ICU is that drug lactation, because the mother will be taking certain drugs. So you should be know that if the mother is feeding the child, that if this drug causes any harm to the child, or the mother can continue the feeding, or the mother should be stopped with the drug. So there is not very much good data for all the drugs regarding this lactation. So these are some references you can refer if you have some queries about lactations. So thank you all for your kind attention, and I am happy to address your doubts and concerns.
Thank you so much, ma'am. Thank you so much for the wonderful presentation. Now it's the Q&A session. Any doubts can be addressed in the chat box, or you can unmute yourself and ask directly to ma'am. And the first question by Nihita. Ma'am, how do you handle the pediatric patients who have undergone to critical stage due to pharmaceutical or by any medical errors?
Okay, so first thing you have to identify what kind of error has happened. Okay, so if it is an overdosing or underdosing, and what should be the measures if it is a renal damage or hepatic damage or a toxicity has occurred. So you should always manage those cases. Luckily, I have not encountered any such patients because in our hospital we are very particular about these cases. In case of certain dilution errors, like some drugs can cause much fatal effect in the early stage itself, like those I've already said, like narrow therapeutic index or drugs, or with the if you are giving in a higher concentrated solution through IV push. So again, it causes extravasation of the IV site, pain, swelling. So unnecessarily, you are putting the child in so much of trouble and increasing their hospital stay. So I should always say prevent before it happens. Prevention is always better than cure, and it should be your ideology in pediatric patients if you're dealing with the pediatric population.
And another question, what are the key components of a pediatric clinical pharmacist involvement in antimicrobial stewardship programs?
Yeah, like I said before, you should be good with the antibiotic agents. Like certain antibiotic agents which we use in adults are not suited in pediatric populations until certain age. Very good examples like tetracyclines, chloramphenicol, quinolone antibiotics. So you should be good enough to know about the what all antibiotics should not be given in pediatrics and what can be safely given in pediatric patients, and be good with your doses. Always go with standard references. Don't blindly search anywhere on the internet. Go with your standard references, and go look and study deeply about the organisms. Okay, so commonly affecting organisms in neonates, infants, and community setup, what all the child will be exposed. So always good with the antibiotics, and go with the standard guidelines is for antibiotic stewardship. Of course, we don't have any proper guidelines for like in adults. We don't have any proper antibiotic guidelines for patients, but always you go with the standard ones.
And the next question really adds to the previous one. How to calculate pediatric dose? Is there any specific guidelines? And the next one even asks for a reference book if possible, since we don't have any updated books for pregnancy and lactation.
Yeah, that is what my last slide was about. I hope you noticed it. So for pediatric drug references, if your hospital is having good access to drug databases like Lexicomp or Micromedex, those are very standard and updated ones, and you will have reference articles along with those databases. And for many drugs, we don't have standard doses. We have very limited pharmacokinetic population studies in pediatric patients. So with those only, we'll get updated doses. And for in case of books, I suggested like for IV drugs, you can always use the teddy bear injectable drug guidelines for pediatric patients. This is by American Society of Health Pharmacists. So it is a very nice and standard and updated book.
And next, hello ma'am, what
That's my
precautions
answer.
do we need to take as clinical pharmacists for patients with epilepsy, especially encephalitis?
So, in case of encephalitis, you need to identify why the encephalitis has happened. It is due to any viral infections or any traumatic causes, so or any bacterial infections. So, you should always get the CSF analysis done to rule out what is the infectious cause. If it is the infectious, what kind of treatment, or if it is due to any other underlying factors which cause the encephalitis. And always go with one or two and anti-epileptic agents. So if one, always the safer choice I would say will be the levetiracetam, which is the first and foremost safer drug in neonates and pediatrics. So if your seizures are not controlled and if you are encountering a status epilepticus conditions in kids, always go with two or three anti-epileptic agents. And be careful with this anti-epileptic agents, because most of the anti-epileptics are hepatotoxic in nature. So if you are giving certain anti-epileptic agents like carbamazepines or phenytoins, so monitor the liver functions in the child and always careful about drug interactions for these drugs.
And the next one, any courses after PharmD to gain deep knowledge about pediatric clinical pharmacy?
Sorry, I didn't get that. Any?
Any courses after PharmD to gain deep knowledge about pediatric clinical pharmacy?
Okay, courses. As of now, I know there is no specific courses available. Uh, you can learn it on your own and practice. You practice well in your pediatrics department for around 3 to 5 years. Then you can, interested, you can move to board certifications, pharmacy specializations. As of I know, there is like no pediatric residency programs available in our country, and even I am not sure about that. If you all know any, means please suggest one for me also, because like for oncotherapeutics or oncology, for pharmacotherapeutics, we have residency programs being offered in India, and for pediatrics, I don't think we have one.
The next, ma'am, I saw a pediatric patient who was prescribed with clobazam for epilepsy. Is it rational or any other drugs needed?
Yeah, clobazam is a widely chosen agent in pediatric population. It is having a good safety in pediatric patients, and especially in case of uh, seizures due to fevers, which are called as epilepsies in childhood, which is a common agent. We'll use to prevent. We'll use as a preventive measure also. Whenever the child is having a high grade fever, we can immediately give them a clobazam dose, which will prevent this, so those seizure episodes in those children. So usually this kind of seizures will resolve on its own as the child grows, but until then they should be closely monitored, and whenever they are having a high grade fever spikes, we can use this clobazam as a prevention to from seizure attacks. Febrile,
And
I can say febrile seizures.
okay, ma'am. Can you suggest some reference for pediatric dose calculation? I think ma'am has answered it previously. The next one, ma'am, can you mention digoxin was given overdosed? How to treat the overdosed condition?
Usually, digoxin is very narrow therapeutic drug even in adults. So, if you are giving it in a very overdose, the child could have fatal arrhythmias, and that consequences would be deadly. And as of I know, like digoxin antidotes like immunofab, all those things are not very much used in pediatrics, and there is no much safer studies for it. So I always say that don't go for that extreme. Always be cautious in dosings.
And I think that's it, ma'am. Thank you so much for clearly and patiently explaining the doubts and making it clear about pediatrics. Thank you so much for your time, and thank you.
Thank you, RX doctors and organizers for having me here. And thank you all. I hope I have addressed all your queries. Thank you.
Thank you, ma'am. And now we are going to move to the third session, our third speaker today, Dr. Muteshwaran. The theme on which he'll be speaking about is soft skill training program for PharmD. He is a clinical research associate and site manager, Directorate of Research, SRM Hospital in Chennai. I know that much more of us will be familiar with him. For the people who do not know, Dr. Muteshwaran started his career journey is characterized by a strong academic foundation and dedication in advancing the field of clinical research. Here is a brief overview for his career trajectory.